to go over chapter 25, the renal, genitourinary, and the gynecologic disorders. So the first things first, if you are not familiar with the anatomy, make sure that you go back and watch the renal anatomy and the reproductive anatomy videos that I've got posted as well. So when we are looking at our general assessment here, we're going to do scene size up. There's some things that can give you some clues as to whether if their problem could be a urinary system problem or a reproductive system problem. We're going to find out what their chief complaint is. Remember that what they think the problem is and what the actual problem is are not always the same. We're going to form our initial impression. What we're looking for here is just, are they sick or not sick? Some things that we're looking for: dialysis access sites, any kind of dialysis equipment if they do peritoneal home dialysis, if they have a Foley catheter, any kind of fishy or ammonia type smell could be renal failure as well, both acute and chronic. So we're going to look for or ask for any decreased urinary output, and this is going to be what's compared. This is going to be compared to what's normal for them. So, they're not usually measuring their output, but what we want to find out is, are you urinating more or less than normal? All right, we're going to ask about any blood in the urine, any hematuria. We're going to ask about any weakness, dyspnea, any flank pain, changes in urination in general, ultramoral status, anything like that. Those are all things that we want to find out because they can lead back to or hint at a urinary problem. All right, some things that you will see. So if it's the fluid and electrolytes that are affected, you will see hypertension, hypotension, you may see some edema, you may see the ascites, that fluid build up in the abdomen, you may hear crackles, you may see impaired blood clotting, bruising, and anemia with your cardiovascular hematologic systems. You may see headaches, ultramoral status, cramps and twitching with your musculoskeletal and your neuromuscular. You may see anorexia or nausea, bleeding, or nausea, vomiting with the GI bleeds in your GI. You may see pruritus, which is itchiness or scratching. You may see a uremic frost or jaundice, pallor, rash, all these different things with the skin systems. You may see signs of easier infection or immunosuppression with your immune system, and of course the decreased urinary output with your renal system. So this right here, you see the little white specks, that's actually a uremic frost. And what happens, this happens where you have severe kidney failure and you are not able to rid your body of the byproduct. So we'll actually start to seep out through the skin. So primary assessment, of course, we're going to make sure the airway is open and good, patent, and we're going to make sure they have adequate ventilations. If not, we will take steps to do so. We're going to give them oxygen if needed. We're going to make sure that they have adequate circulation. We're going to evaluate for hyper and hypotension. Hypertension is often a cause of renal disease, and hypotension is a complication often of renal failure and dialysis, where they may pull too much fluid off. All right, we're going to look for any signs of electrolyte abnormalities, because these patients, especially if they're on dialysis, they can develop these very easily, and it can result in some life-threatening dysrhythmias. All right, we're going to look for any kind of bleeding. I've seen one patient who had a bleeding shunt, and it looked like a murder scene. There was so much blood everywhere. It's ridiculous how much they will actually bleed. All right, once we've looked at our ABCs, we're going to look at our secondary, get our baseline vitals. If they do have a hemodialysis access point, a shunt in an extremity, don't take blood pressure in that extremity. Okay, now what you will see is that as people are on dialysis for a long time, those shunts eventually will kind of go bad, and so they will put in a new shunt. So if they have shunts in both sides, ask them where they take their blood pressure at the dialysis clinic and take it the same place that they take it there. So that's your backup there. You want to use the non-active site. All right, if they're unresponsive, get a history from your bystanders, family, or something like that. Do your rapid secondary. If they are alert, we're going to get a focus history and exam based on what they say is wrong. We're going to look for signs of dehydration or fluid, too much or too little. If you are allowed to do EKG or 12 lead, then you would want to do that, because that can give you some very important clues on their electrolyte status. We're going to check for any diabetes, created blood sugar, especially if they are diabetic and or if they are altered mental status. We're going to note their skin temp. Now, with skin temp, this one's kind of tricky. Now, some places carry thermometers. A lot of places don't carry thermometers in the pre-hospital setting. We rely on, let's touch them and see what they feel like. Do they feel hot? Do they feel cold? That's very subjective. Right now, my hands are kind of cold, so if I were to touch somebody even normal temperature, they would feel warm to me because my hands are cold. On the opposite, if your hands are hot and sweaty, then somebody who does have a fever may not actually feel that warm because they're going to match the temperature of your hands. So just keep a grain of salt with the temperature if you're touching them. And if you do use your hand, make sure you're using the back of their hand, and you want to feel kind of on their core if you can, their neck, their forehead. You don't want to feel, you know, just on their arm or skin, you know, something like that. We're going to look for any changes in urination or the color of urine, the smell. Is it cloudy? Has there been blood in it? Any difficulty with urination? Any more frequent? Any pain or inability to urinate? That kind of stuff. All right, any past medical, and then look at their medications that they are taking. Now, with your renal, there's one called, it's kind of like the renal triad, where they'll have high blood pressure, diabetes, and renal failure. Oftentimes, your renal disorders will go hand in hand with other medical problems, okay? And when you start having kidney issues, of course, you're going to have homeostasis issues, and it's going to kind of trickle down effect and affect all of the organs, other organ systems as well. Now, ultimately, the treatment, the cure for kidney disease is a kidney transplant, but there are a lot more people who need kidney transplants than there are kidneys. Now, luckily, you can do a living transplant, so you can give up one of your kidneys if you're a match for somebody else under certain criteria, but there are still way more people who need them than there are kidneys available. So the kind of the holdover is dialysis, and they will do dialysis to rid the body of the toxins that build up that the kidneys normally would rid the body of. Okay. If they have a Foley catheter, Foley catheters are placed when people, a lot of different reasons, but usually when they are not able to get up and go to the bathroom for whatever reason, whether it's illness or injuries or whatever. But if you have what's called an indwelling Foley catheter, it's a tube that leads into the bladder. So it is a kind of a direct entryway into the body. So they're more prone to have infections if they have a Foley catheter, or even a suprapubic catheter where they actually go straight into the abdomen to the bladder instead of through the urethra. So treatment here. With your renal patients, you want to be very cautious with fluid administration. You want to be very careful with the amount of fluid that you give a renal patient, because if they're not making urine, they can't get rid of that extra fluid the same way you or I could. So you want to make sure that you only give them fluids if absolutely necessary. Make sure you check the breath sounds frequently for any signs of fluid overload, and if they have crackles, do not give them any fluids. We're going to get a baseline for mental status or vital signs, any physical findings, and of course, reassess your criticals pretty much continuously and our non-criticals every so often. Alright, so with anemia is what? Lack of red blood cells for whatever reason. So why do you think that would be an important complication to identify? Alright, so especially in the setting of renal patients, with your anemic patients, they're not going to carry oxygen as well. For whatever reason, they're not going to carry it as well. So they're going to be even more prone to homeostasis issues than just a normal, ordinary person. Now, with your renal disorders, it is going to be related to the function of the kidney. So how well is this kidney actually working? Oftentimes, it is a complication of diabetes or hypertension. It occasionally can happen as a very severe side effect of a bad case of strep throat or something like that, some other illness secondary to a trauma that hypoperfused the kidneys. But usually, it's going to be secondary to diabetes and hypertension, chronic, long-term. All right, now with our renal disorders, they are going to be either classified as acute or chronic renal diseases. Now, acute in this situation could be over hours to days. Chronic's going to be long-term. They are classified by where the problem causing the kidney failure is. So if it is something outside of the urinary system, it's called pre-renal renal failure. If it is within the kidney itself, it is considered to be intrinsic kidney failure. And if it is the problem, if the problem is after the urine leaves the kidney, it's considered post-renal renal failure. It's going to be further categorized by how much urine is actually still being made. So oliguria is making urine but less than 400 to 500 milliliters an hour, which is not a lot. Anuria is where you're making less than 100 mLs per 24 hours. Oliguria, I'm not even going to try that one. The other one there, you're still making 400 to 500 or greater mLs per 24 hours, but you still are showing signs and symptoms of renal failure. All right, and then of course on the opposite end of the spectrum, polyuria, this is where you have too much urine. Usually this is secondary to like a DKA or a hyperglycemia or something of that nature. All right, so an acute renal failure. This is a loss of renal function, which is the decreased glomerular filtration rate, which is how much urine it's putting out, over hours to days. you're going to have this accumulation of these waste products in the blood, and it's going to start causing pretty severe problems. Okay. 60% of these in acute renal failure are going to be pre-renal renal failure. So the problem or the issue is somewhere else in the body that affects the kidney's ability to produce urine. So this might be like a sudden drop in blood pressure, shock, you know, any kind of injury to the kidneys themselves, something like that. Now, your intrinsic renal failure is about 40% of your cases, and this is direct damage to the kidneys itself by inflammation, toxins, drugs, poor perfusion to the kidneys, something like that. And then you've got post-renal failure, which is going to be an obstruction that backs urine up into the kidneys. It's about 5% or so of the cases, not very many, but this might be like a tumor or injury, prostate enlargement in men, something like that. All right. With your pre-renal renal failure, a lot of these patients will be older patients with a history of decreased blood volume, dry mucous membranes, tenting, signs of poor perfusion and poor fluids, you know, inadequate fluid volume within their body. It could be caused by cirrhosis of the liver, sepsis, CHF, a whole lot of different things there. With your post-renal, usually you have signs of your obstruction there. So you will have really bad pain, they'll be unable to urinate, and if you give them IV fluids, it will make the situation worse because their kidney is still producing urine usually. They're just not able to get it out. And then with your intrinsic, this is, of course, damage to the kidney itself. Now, this could be a glomerulus failure, could be from the tubules, the interstitium, it could be the blood vessels. It all just depends on what part of the kidney is failing. With the glomerular, usually this is like a systemic lupus or autoimmune disease that destroys the kidney tissue. Your tubular disorders are usually caused by your toxins like your acetaminophen overdoses or things like that, or ischemia with poor blood flow to it. Your interstitial disorders are usually caused by your medications, and your vascular disorders are usually blood clots or stenosis of the renal artery due to hypertension. So our management, if it's an offending agent, if it's a medication, if it's a toxin, if it's something that we can fix, remove that agent, get it away so it doesn't continue to cause harm. All right, try to get the fluid status as close to normal. All right, any type of renal failure means that their kidneys are not functioning properly and they're going to need dialysis. So we need to make sure that we transport them, if possible, to a facility that a hospital that has in-house dialysis. Some smaller hospitals may not have dialysis and they can't, so they can't manage this patient for definitive care what they need. Now, obviously, if they're in a cardiac arrest or something, then no, you're going to go to the closest facility that can handle it. But if you have the option, go to one that has a dialysis clinic in-house. Now, for your chronic renal failure, these are the patients that on the ambulance you're going to be dealing with a lot. You may have heard like the renal roundup. You're going to be doing dialysis. This is the bread and butter of most ambulance companies. You take these patients 3 times a week, and you drop them off, and then you pick them up a couple of hours later and take them back. This is irreversible kidney function that lasts for greater than 3 months. And what happens is they're retaining all these waste products, and they don't have adequate levels of erythropoietin. They don't, the vitamin D is not active. You've got a lot of different side effects that happens with your erythropoietin. That's the hormone that's going to stimulate the red blood cells. So they end up being kind of anemic as well. Well, what does red blood cells do? They transport our oxygen, right? So it's a trickle down effect that's going to affect pretty much every body system within the body. All right. It may cause some neurological weakness, confusion. Oftentimes they will have increased blood pressure. They may have pitting edema. They may have more inclined to pericarditis, things of that nature, shortness of breath, more thick sputum, metallic taste, anorexia, nausea, vomiting. Whole lot of different problems that can happen secondary to chronic renal failure. All right, now your uremia, this is where the urea is not excreted by the kidneys, which is one of the products of urine. It causes a fishy odor and nausea and vomiting and diarrhea in the patients. It can cause GI bleeds, heart failure, dysrhythmias, all kinds of really nasty things that can occur with this, okay? With this uremia, they need dialysis or they need a transplant. And almost a quarter of the cases are caused by hypertension. So y'all, if blood pressure's high, keep it under control. Take those medicines to help keep it under control and limit your salt. All right. So your glomerulonephritis, this is an acute infection in the glomerulus and the nephrons. Increased blood pressure, you may have some facial edema, low-grade fever, overall weight gain, headaches, increased blood pressure. With this, just recognize that there's a problem. This is the one that's more likely to happen from like a infection, strep infection or something like that. The treatment usually is going to be dialysis. Sometimes the body can fight it off and be okay, and then other times they may require long-term dialysis. Now, when we are talking about hemodialysis, okay, this is the one where they go to a clinic, they sit there usually for 2 to 3 hours, and then they will, all the blood in their body is pulled out of their body, run through a machine, not all at once, of course, but it's pulled out of their body, run through a machine, filtered, and then put back in the body, which is really amazing that we can even do that. So what they do is they will actually put a shunt in a graft, and it is basically like a man-made vessel, and it's actually going to form a bridge between the artery and the vein, because you know if you put a needle in a vein over and over and over again, it's going to eventually develop scar tissue, and then you'll no longer be able to access it. So they put these grafts in so that way they can actually stick the graft, pull all the blood out, put it back in without having to repeatedly damage that vessel over and over and over again 3 times a week. When you feel this, you should see it. It'll be like a little horseshoe-shaped thing under the skin, and when there's blood flowing through it, it'll have what they call a thrill. It's a very light vibration. So you put your hand lightly over it, you should feel that vibration. If you don't, that means the graft may have clotted. That's not good. All right. If it's warm or very tender, there may be some kind of infection. So just manage appropriately. And there's a kind of an old school hemodialysis machine, but it's very, very complicated, very cool though. All right. So they also do subclavian area catheter access ports, usually in the arm, just different areas where they may put it. Depends on how long the patient's on dialysis, and you know, the longer they've been on dialysis, the more graft sites they typically have. All right. Now, your complications of hemodialysis: blood clots, infection, thrombosis, stenosis, bleeding grafts, hypertension, pruritus, rashes, hyperkalemia. These patients who are on dialysis are some of the sickest patients you will encounter because of renal failure, because of those electrolyte imbalances. Before dialysis, they're hyper everything. After dialysis, they're hypo everything. So they really swing widely around the dialysis. Now, for your peritoneal dialysis, this one is one that is actually done multiple times a day, and it's done at home or wherever that person may be. So what happens is you've got a catheter in the abdomen, and they put a large amount of the specific fluid in the abdomen, and the toxins are actually going to equalize through osmosis. And then they're able to drain the fluid back out. In my understanding, it takes about 20 to 30 minutes, and they just do it multiple times a day. It's not as efficient, so their diet and fluids have to be a lot more controlled. But the benefits are that you don't have to go sit in a room for 3-4 hours a day, 3 days a week. You can do it wherever you go. So there's pros and cons there. Now, for a renal transport, like I said, a lot more people need it than there are organs. The fun thing about this, or the neat thing, I think, is that the kidney is actually placed in the lower abdomen and attached to the iliac arteries, and you can feel it if they're thin enough on an abdominal exam. They don't take the other kidneys out. They just attach this new one in, and it takes over, which is just really awesome, I think. Now, they will take immunosuppressant medications for the rest of their life. And so, first-year survival rate's about 85%. It doubles their lifespan, doubles their expected lifespan without having a kidney transplant. So, there are some risks, but there are some benefits as well. All right. Now, with your acute urinary retention, this is more common in men, and it's often an underlying problem with benign prostatic hypertrophy, or BPH. And this occurs mostly in older men, but what happens is that prostate enlarges to prevent the flow of urine out of the bladder, and it causes pain and discomfort, ultimately infections, and can cause acute renal failure. This is why, when you turn about 40 or so, usually, the doctor wants to check your prostate. It's not super comfortable for most men, but you should do it, because otherwise your stuff may stop working. All right. Nervous system injuries, spinal injuries, over distension of the bladder can lead to urinary retention. We give mildly IV fluid boluses, it makes it worse. So we want to make sure that we are not making the situation worse. Now, renal calculus, and not the math kind, but renal calculi are kidney stones, all right? They have a much higher incidence in males, but they can happen to anyone of any gender at any age. Nausea, vomiting, they may have pain in the urine, and what you see, I picture, like, if you're from the South, the sweet gumball that fall out of the trees that you step on it barefoot and you would say some really bad words. They look, if you look at them very closely in a microscope, they actually kind of look like that, almost like little asteroids or something, little sharp, spiky parts to them. So as they're moving through, they can actually cause some bleeding within the kidney and in the ureters as they pass through. All right, that pain often starts in that flank area and will actually radiate, and if it's moving, it will follow that stone as it moves through the ureters down to the bladder and urethra and so on. They'll usually have a colicky pain, like a real sharp, stabby, sudden pain, and it may be intermittent depending on how that stone is moving. Some of them can pass through the lower urinary if they're less than 6 millimeters in size, but if they're too large to pass, then they'll actually kind of go in with a little laser and kind of break it up into smaller pieces. In very severe cases, they may actually have to go in and surgically remove them. All right. There is some anecdotal evidence, I've heard anecdotally that a beer a day, or beer when you feel the start onset of a kidney stone will help. Something about the beer will help break it up. I've never had a kidney stone, knock on wood, and I'm not particularly big fan of beer. So, but that's what I've always heard. Of course, you know, only if you're of age and legal and don't have any other reasons you shouldn't drink a beer. Take it for what it's worth. All right, urinary tract infections, or UTI. With this, you know, they're very common in females. They're more common in females than males because females have a shorter urethra. The bacteria gets to the bladder a lot faster, and it makes it up there before it gets washed out, essentially. All right, it is more common in your patients with your Foley catheters. All right, and if it gets up into the bladder itself, it would be considered to be like a cystitis or something like that. All right, increased frequency in urination, the urge to urinate, difficulty urinating, painful, cloudy, or stinky urine can all give you signs of a UTI. All right. So, transport, patient position of comfort, IV fluids, consider pain management if you can do so. All right. If you have a Foley catheter, you know, we want to consider, especially if it's an elderly patient who's confused, who has a Foley, consider sepsis secondary to a UTI. That is a super common call, especially in nursing homes, long-term management, where they have Foley catheters. It just seems like it just happens a lot. They'll be burning up hot, and they'll just get septic really easy from this. All right, they may pull. I've seen people pull, especially if they're older and confused. They pull the Foley out, or it gets caught on something. A lot of different reasons somebody may have this, but you want to make sure that you are keeping it lower than the bladder. You want to make sure it's unclamped so that way it doesn't back up blood flow. And you want to make sure that when you move it, that you keep it lower and that you make sure that it's not going to backflow into the bladder and that it doesn't get caught on anything and pull. All right, if it pulls out with that balloon inflated, it can cause severe trauma. Like I said, you know, if you've got an elderly patient who's showing signs of being ill, and especially if they have a Foley, consider potential for a UTI. Now, Fourier's gangrene. This is a bacterial infection of the skin that affects the genitalia and the perineum. Usually from a wound or abrasion to the skin. Men are 10 times more likely than women to develop it, and that can be fatal. All right. So some signs that you may see with this, crepitus around the area of the scrotum and the perineum. You know, you get a spongy feeling under the skin, pus from any kind of gray lesions, foul odor, severe swelling of the scrotum. If they're lethargic, they're febrile, life-threatening. All right, phimosis and paraphimosis. So with this is the phimosis is where the foreskin cannot be pulled back over the head of the penis, and urine will actually build up in the foreskin and cause infections and real bad irritation and skin breakdown. All right, now the paraphimosis, the foreskin of an uncircumcised male is retracted, which constricts the drainage and allows the glands to swell, which causes tissue death. So for that case, ice pack, not directly on it, but through a layer cloth to decrease swelling, and then transport. They're going to have to cut the foreskin in the ER or the operating room to release it. All right, priapism. This is a prolonged, painful erection of the penis more than 4 hours. This is where the corpus cavernosa has filled with blood and it can't drain out for whatever reason. All right, it could be sickle cell, could be some other issue. With this, transport. There's nothing else we can do about this other than note and transport. Okay, you can ice pack, try to minimize any swelling, but that's usually not going to really truly fix the problem. Now, testicular torsion, right? This is where the testicles have rotated and twist that spermatic cord, and this cuts off blood supply. So if it's not reversed, that testicle is dead. So make sure that if they have this, and it's usually they're going to have a similar pain that occurs intermittently until it finally twists and stays, causes nausea, vomiting, it may have blood in the semen, lower abdominal pain, a lump or swelling in that testicle, and severe pain. And it is most common in infants in their first year of life and then teenage boys. Now, epididymitis and orchitis. All right, epididymitis is inflammation of the epididymis at the backside of the testicle there. More common in young men with STIs and elderly men. Ice and elevation of the testicles. All right, orchitis, inflammation of the testicle itself. Not much you can do there. Ice it if you want to. Trauma to the male genitalia. It can be blunt or penetrating trauma. It could be insertion of a foreign body into the urethra. It could be an accident. It could be self-induced. It could be sexual assault. It's not as important so much as why it got there as what happened. All right. If you have a laceration of the scrotum and the testicle falls out, the penis can actually break. That you can break that tissue, especially if it's erect and it causes something lands on it the wrong way or gets hit the wrong way. So it can be very, very painful for the patient, and not to mention usually can be kind of embarrassing as well. So with this, you have to approach it. It is what it is. I'm not so much concerned as to how all this stick got inserted into your urethra as it broke and now I need to manage it. Okay, be comfortable, be caring, be knowledgeable. Give them privacy. Just make sure that you take care of them. Same rules kind of apply to your GYN stuff, your gynecological disorders. Now I'm going to go ahead and tell you, it's a whole lot easier for a guy, a male provider, to kind of manage a patient who's having a male reproductive issue. They're going to inherently usually be more comfortable. Same with females. Females are going to be more inherently comfortable talking to a female usually about a gynecological issue. With that said, if you are the opposite sex, you've got to be professional. You've got to make sure that they know that you're not judging them, that you're giving them the privacy they need, and that you are being utmost professional. All right. Some of your gynecological disorders could be, abdominal pain. It could be abdominal bleeding or discharge. A lot of different things that can go into that. So we're going to get a good history here. History of menstrual cycles. How many pregnancies, the GPA, that stuff. Any contraceptives. The old adage, if you're not stopping it, if you're not trying not to, you're trying, kind of thing. If they're sexually active and they're not on birth control, then there's a possibility they could be pregnant. Birth control fails. So if they're sexually active, you want to consider the possibility of that. Right? Most of our management here is going to be supportive care. There's not a lot we can do about most of these, so it's going to be supportive care and getting them to the hospital as safe as we can. Right, some gynecological causes of your abdominal pain. The pain with ovulation, the middle smirch. Usually this is a unilateral pain and it will just be there and then it'll go away. But this is usually, once a month right before ovulation. Your ovarian cyst, endometriosis, endometriitis, ectopic pregnancies, pelvic inflammatory disease. These are all things that can cause abdominal pain that are actually gynecological in nature. Now, with abnormal vaginal bleeding, could be a pregnancy-related problem. It could be just super heavy periods, especially with endometriosis. It could be due to trauma. You want to find out how many sanitary pads or tampons they've saturated with blood in 1 hour's time. Now, it takes a lot to saturate. We've actually done some experiments in class before, not with blood, obviously that's gross, but with just like colored water to saturate different assorted pads just to see, and tampons just to see. And usually on average, the average pad would hold about 100 mLs before it started leaking. So that's a lot. So if they're actually truly saturating the pads, they've lost a fair amount of blood there. All right, so you really want to make sure that you're looking for any signs of hypovolemic shock. All right, now some other things that you may see. Toxic shock syndrome. This is associated with tampon use sometimes, but what you'll see is a lethargy, vomiting. You'll have a rash, like a sunburn, all over their body. And if it's far enough along, the palms and soles of their feet will actually slough off. They'll have real bad diarrhea, sore throat, severe fever, headache, confusion, and it is associated with the menstrual cycle and the use of tampons. Very rare, but it does occur. All right, now as far as female genital trauma and sexual assault, you may have small cuts or lacerations in the pediatric population or anybody but from straddle injuries. This was like horseback riding or something like that. If this occurs, control any significant bleeding. Usually it's going to be a ab pad between their legs inserted in the underwear or something of that nature. If they have discomfort, swelling, you can externally apply an ice pack and consider sexual assault as a possibility. It could be that they don't want to tell you. All right, for genital trauma and sexual assault, could be male, could be female. Preserve any evidence of legitimate concern. No washing of injuries or anything of that nature. You may wash away any evidence. Garments, any clothing or anything that's removed should be placed in a paper bag. We want to discourage them from washing, douching, bathing washing their hands, bathing, anything of that nature. The sheets that are on the stretcher or anything of that nature, cloth, blankets, or anything like that, should also stay with the patient and go to the hospital with the patient because it becomes part of the evidence as well. With this, oftentimes it's going to be more of a psychological need for the patient, reassuring the patient. We're not asking questions, implying that if they're at fault, we're not making statements. We document anything they tell us, but don't push them for talking. If they want to talk, they'll talk. All right? They may feel some shame, but, we've got to manage that patient appropriately. With your sexually transmitted infections, all right, or STDs, STIs, they may be embarrassed. They may not want to get treatment until it becomes really bad. Be empathetic. Don't be a judgy McJudgy. We're not there to judge. All right? It is what it is. We're there to transport them and treat them appropriately. So you got to make sure that you understand the anatomy, the physiology, how everything works. All right? We want to make sure that we understand how the kidney plays a part in homeostasis, and when that goes wrong, how it leads to your life-threatening complications. We want to make sure that we understand that both males and females of any age can be a victim of sexual assault and that we know how to appropriately treat them. And we want to recognize that some of your gynecological disorders will present with abdominal pain or vaginal bleeding. That may be the only outward sign that you get.